Dr. Anjana, sorry. Her topic is multimodal imaging biomarkers in eyes with the uveal effusion syndrome undergoing surgical management. Dr. Anjana.
Good afternoon. My topic of presentation is multimodal imaging biomarkers in eyes with uveal effusion syndrome undergoing surgical management. Uveal effusion syndrome is a rare condition that presents with serous choroidal effusions, often associated with serous detachments and shifting subretinal fluid. It is of three types: type 1, type 2, and type 3. The classification we used, type 1, included eyes with nanophthalmos, that is axial length less than 20 mm, and scleral thickness more than 2 mm on B scan. Type 2 US non-nanophthalmic eyes with axial length more than 20 mm with mild hypermetropia and scleral thickness more than 2 mm on B scan. Type 3 US included eyes with normal scleral thickness and normal axial length, but having features of idiopathic chronic exudative retinal detachment and pachychoroid spectrum. Pathophysiology, thickening of sclera leads to impermeability of transscleral outflow, which again leads to fluid accumulation in choroid, and congestion of vortex veins, which leads to extravascular leakage from choroidal vessels, dysfunction of RP pump mechanism, and finally subretinal fluid accumulation. Our aim was to study multimodal imaging biomarkers in uveal effusion syndrome and correlate with the response to surgical management. It was a retrospective interventional study. 6 eyes of 5 patients who underwent partial thickness sclerectomy and vortex vein deroofing with or without external drainage of subretinal fluid for UAS were studied. Coming to the methodology, the EMR of the patients were retrieved and reviewed. The following factors were analyzed. First is preoperative visual acuity. Mild visual impairment included eyes with visual acuity better than 618, moderate between 618 to 6/60, and severe worse than 6/60. The extent of retinal detachment, whether both the peripheral retina and macula were involved, was analyzed. The preoperative central foveal thickness, subfoveal choroidal thickness, the type of surgery done, and number of quadrants operated. Postoperative visual acuity, whether improved, remained stable, or worsened, and postoperative central foveal thickness and subfoveal choroidal thickness. Complete resolution of subretinal fluid was taken as anatomic success criteria. Careful search was made for biomarkers in preoperative infrared image, fundus autofluorescence image, FFA, ICG, and EDI OCT image, and postoperative analysis of infrared reflectance and EDI OCT images. Coming to the results, we had the 6 eyes, and out of this eyes, 3 eyes had type 1, 2 eyes had type 2, and 1 eye had type 3 uveal effusion syndrome. The mean age of our patients was 61.2 years. The range was between 51 to 72 years. There were 2 females and 3 males. 2 eyes had mild preoperative visual impairment, 2 eyes had moderate, and 2 eyes had severe impairment. Peripheral choroidal effusions, inferior exudative retinal detachment were present in all the eyes. Macular reserve was present in 5 eyes and absent in 1. This eye had undergone a prophylactic surgery due to other eye involvement. All patients underwent partial thickness sclerectomy and vortex vein deroofing, done in 2 quadrants in 5 eyes and 3 quadrants in 1 eye with type 1 uveal effusion. The eye with type 3 also underwent external drainage of SRF. 2 imaging patterns were found. The first pattern was seen in type 1 and type 2 uveal effusion eyes. There were focal hyperreflective spots seen on infrared reflectance and fundus autofluorescence, and corresponding hyporeflective spots on FFA ICG and hyperreflective spots on EDI OCT within the retina or in the subretinal space or in the choroid. These spots, for which no corresponding lesions were seen clinically, could be extravasated proteins from the choriocapillaries trapped in the choroid subretinal space or retina, and this suggests a venous overload due to blockage of venous return across the thick sclera. The second pattern, that is subretinal choroidal hyperreflective foci on EDI, for which there was no corresponding hyperreflective material on FAF and infrared reflectance image. These could be shed photoreceptors. Coming to our surgical techniques, our primary aim was to decrease the scleral thickness and relieve the congested vortex vein. So conjunctival pyrectomy followed by muscle tagging, and partial thickness sclerectomy was done until the brownish hue of the underlying choroid was just seen, and then vortex vein was identified and deroofed. The best corrected visual acuity improved in type 2 uveal effusion eyes from hand movements to 6/18, remained stable in all the other eyes and worsened in none. In the eye with type 1 uveal effusion syndrome, for which no macular reserve, one eye had no macular reserve, and in all the other eyes, the central foveal thickness decreased at 1 month follow-up. The inferior exudative retinal detachment was also found to be resolving in all follow-ups in all the eyes. All patients also showed a slight decrease in the subfoveal choroidal thickness in the first follow-up visit, and in subsequent visits, there was a very slight increase, but it was always lower than the preoperative value. The first patient had type 1 uveal effusion syndrome, and he had peripheral choroidal effusions, inferior exudative retinal detachment, and there is focal hyperreflective material seen on the blue autofluorescence, and we can see corresponding hyperreflective area in the early phase of ICG mainly, And the OCT is showing hyperreflective area within the retina. Also, there are hyperreflective spots within the retina, in the subretinal space and also in the choroid. And post-surgically, this patient with predominant type 1 pattern did very well with excellent anatomic and functional outcomes. Second patient had type 1 UV effusion syndrome. Here we can see the infrared reflectance showing hyperreflective spots with corresponding hyperreflective areas in the EDA OCT and also in the blue autofluorescence, and the ICG FFA is showing hyperreflective areas both in the early and late phases. So another patient with predominant type 1 pattern with good anatomic and functional outcome. And this is the second eye for which prophylactic surgery was done. And no biomarkers are seen. And this is the third patient, type 2 UV effusion syndrome, hyperreflective spots on FFA, corresponding hyperreflective areas on infrared reflectance, and also in the OCT type 4 patient. ICG is showing choroidal granularity, hyperfluorescence increasing in the late phase. And patient 5, here there is mainly pachychoroid type of spectrum in the infrared reflectance in the FFA ICG. And those were our clinical data. Coming to the discussion, recently there was a proposal that CSR is a venous overload choroidopathy and is at the other end of the spectrum of UV effusion syndrome. Hence, we included eyes with idiopathic chronic retinal detachment and pachychoroid spectrum in the type 2 USU group. So these biomarkers could be proteinaceous exudates, and these were seen in infrared reflectance and fundus autofluorescence, and these could act as biomarkers to predict surgical outcome. So the surgeon can proceed with surgical rather than conservative management if this pattern 1 is seen. To the best of our knowledge, no previous study has been done on multimodal imaging biomarkers. The limitation is that this is a very small case series with only a short period of follow-up for each group. Conclusion, multimodal imaging biomarkers could help in predicting surgical management in UV effusion syndrome eyes. Thank you. These are my references.
It's a good collection of cases, but your topic was biomarkers, no? Multimodal biomarker, imaging biomarkers. You approach the presentation from that angle. The biomarkers you put at the last, and you had to rush through also. So you start with the initial 1 minute you lost in describing the case. As a free paper, we need not take a class on what the disease entity is, because that's understood. So you have to come to directly to your, just a short introduction and directly come to your slides. Plus, you are totally away from the biomarkers. You see, seems to be an addendum rather than the primary focus. Even though title says so, your primary focus was not pointed. You should directly start from what are the biomarkers seen, and how many cases you saw, and what are the biomarkers seen in each case, or how many cases you saw the biomarkers, how they changed after the treatment success. The angle of approach, the title does not is pointing towards one direction, and your presentation was slightly deviated from what it should have been actually. Otherwise, a good presentation of cases.
I just wanted to ask if you tried steroids in any of these cases.
Ma'am, actually we gave Diamox to a half dose, that is 125 milligram tab, and also we had tried Dosox. Oral steroid we hadn't tried because in the first 2 patients with type 1 US, the clinically itself it was pointing more towards, we had done the routine workup to rule out other causes of exudative retinal detachment, but clinically itself the diagnosis was straightforward because non-ophthalmic eyes with all these typical thick sclera. So we straight away went for surgery in patients.
What about
And we had tried this
type 3?
oral Diamox and Dosox prior to surgery in 2 patients.
Okay.
There's a Shields article, which says initial
Yes,
dose
sir.
of steroids should be tried. Majority of the patients are resolved with steroids. If it doesn't happen, you can do surgical management. There's an article by Shields, a big series.
Mm.
I mean, that's the basis of giving steroids in UV effusion syndrome.
Thank you. Thank you.
Next, we have Dr. Ashwathi. Hold on. Just next we have on the podium Dr. Ashwathi Menon. The talk will be on absent. Not there. Okay. The talk is out. Okay. Then the third we have Dr. Hema, VK Hema. She'll be talking on the effect of oil versus gas on macula in retinal detachment, an OCT based study. Okay, please go ahead.
Good morning, all. Intraocular TAMNate agents are used in complex retinal disease like diabetic and retinal detachments, etc. They provide a surface tension across retinal breaks, and they prevent the fluid into the subretinal space until the retinopexy provide a permanent seal. The aim of the study is to evaluate the anatomic and function effect of siliconol and C3F8 on retina, and also finding out the cause behind the unexplained visual loss in through OCT evaluation. This is a prospective study of 37 patients, 20 patients with gas and 17 with silicon oil. Two senior surgeons had done the surgery from Jan 2020 to May 2023, and the eyes were compared with the other normal eye of the patients. All patients who had diseases affecting macula and optic nerve were excluded other than RD, and media obscuring diseases were excluded. Also, if the other eye or other normal comparing eye also had any macular optic diseases, they were excluded. Grade C PVR or more or use of perfluorocarbon were also excluded. And the findings noted were slit lamp examination, visual acuity, fundus evaluation, intraocular pressure. OCT was done at follow-up visit, and statistical analysis was done with SPSS software. And 65% were males, and their average age of presentation was 45 years. Mean duration of detachment was 8.6 plus or minus 8.2, and gas it was 8.6 plus or minus 8.1, and the evaluation was done before silicone oil removal. Mean intraocular pressure was normal, and 66 patient had retinal degeneration in other eye. The BCVA mean was 0.73 plus or minus 0.35 logMAR, and 36% patient had a 4-line improvement. Coming to the segmentation of the retinal layers, central macular thickness didn't have any comparable differences in both oil and gas filled eye when compared to the other normal eye. Coming to the layers, and gas filled eye had thickening in RNFL, GCL and inner nuclear layer, but oil filled eye had no difference in any layer. There was no difference in inner plexiform and outer plexiform layers in gas filled eyes. Coming to outer nuclear eye, there was a significant thinning in outer nuclear layer in both gas and oil filled eye when compared to the normal eye, and this was correlating with the visual decrease in visual acuity. There was no significant changes in RP and subfoveal choroid thickness, and inter-group analysis also showed no difference between gas and silicon oil filled eye. Coming to the discussion, the central macular thickness studies show thinning in central macular thickness, but our study showed no comparable differences. In retinal segmentation, previous studies has showed thickening in the inner retinal layers similar to our study, and also thinning of ONL was noted in many other studies similar to our studies. The inner retinal thickness compared to the other normal eye inner study can be explained by two mechanisms, then which is already explained in many studies. That is due to retinal edema caused by retinal detachment and also surgery-induced retinal edema. The outer nuclear thinning in both the groups is explained in different ways, and also it is controversial, but we like to highlight some points regarding the effect of tamponade on the retina. The outer nuclear layer, the retina as a whole is affected by the mechanical effect of the tamponade, and the tamponade had some characteristic features like buoyancy, surface tension, and also the duration of the tamponade also affect the retina. But we have not studied the duration and correlated it with visual acuity, so we consider it as a limitation of our study. So when a tamponade is applied, the net force is equal to the buoyant force minus the weight of the bubble. Since the difference in the buoyant force and difference between the surface tension of the gas and aqueous is different, vastly different, but compared to aqueous and silicon, it is only a small value. When we calculate this, the net force applied by the gas is more compared to the silicon oil on the retina. So this video shows the effect of bubble on the retinal layers. You can see that ONL is thinning. Why the inner retinal layers and RP or choroid is not affected should be further evaluated, and maybe due to the difference in the architecture. And also outer nuclear layer has blood supply from the choroid, and when compared to the other inner layers, and due to the edema there can be obscuration of the blood flow causing further thinning. So we conclude that the inner retinal thickening seen in our study can be due to the retinal edema as explained in previous studies. Thinning of outer nuclear layer can contribute to delayed and incomplete visual recovery. More studies need to be done for understanding the exact pathological process in this disease. And we also think that our study can target, put forward some light into targeting certain retinal layers for neuroprotection needed in the future.
I mean, as a like little bit new angle at which you are looking at, good only. You could have put some additional pictures to show example cases. That is one thing, and how you made the cuts, and what machine and how you made that cuts. That is, it would have been a little bit more descriptive. Plus, the theory. One more confounding factor will be the duration of RD itself. So the longer the RD, you have some changes in the both the outer and inner. So that will be a confounding factor. Sometimes whether you had intentionally taken equal duration of RD in both the groups or a retrospective study, no?
Yes, sir. Actually, we have taken
Prospective, okay.
prospective, sir. We have taken only acute cases.
Acute case.
Like chronic RDs, we have excluded.
Okay.
But also, we wanted to.
Duration of RD was comparable. Right?
Yes, comparable, ma'am. 8.6 plus or minus 8.3.
And emulsification of oil wasn't considered. How long after the oil injection was it removed?
Mean period was 4 months. 4 months.
Was emulsification of silicone oil considered as far as your
Yes, ma'am. Yes, sir. The cases with the silicone oil emulsification were not taken
not taken?
because already it is explained the chemical
So at
effect.
4 months, none of your patients silicone oil was not
That's
emulsified.
why we have a small number of cases.
Thank you.
Thank you, sir.
Okay. Next we have Dr. Jismary Santosh will be presenting on vitrectomy in vitrectomy in Terson syndrome, outcomes from the tertiary care center in South India.
No, the screen. On the screen, another person's present. Dr. Ashapurna's present. One second. In this section. Good morning, everyone. I'll be presenting on vitrectomy in Terson syndrome, outcomes from a tertiary care center in South India. Terson syndrome is an intraocular hemorrhage occurring in the setting of an intracranial bleed resulting from an acute elevated intracranial pressure. Treatment options include observation for spontaneous resolution and vitrectomy in cases causing significant visual loss. Due to the associated systemic mobility, there can be a delay in the diagnosis and intervention of the ocular hemorrhage. Currently, there's no consensus on the timing of vitrectomy in patients with Terson syndrome. One prior report advocated surgery within 90 days for better visual outcome. There are other reports have advocated surgery in the event of an unwanted sequelae or complication. The aim of our study was to analyze the outcomes of vitrectomy in non-clearing vitreous hemorrhage and Terson syndrome, and to analyze the association between baseline visual acuity, etiology, age, and timing of surgery to the final visual outcome. This was a retrospective observational study of EMR cases of consecutive patients diagnosed with Terson syndrome from January 2014 to January 2022 at Giridhara Institute, Cochin. All patients with an non-resolving vitreous hemorrhage associated with Terson syndrome who underwent plasplanar vitrectomy and was performed by 5 different surgeons with a minimum follow-up of at least 3 months were included in the study. The patients excluded were other causes of ocular hemorrhage, including ocular trauma, orbital fractures, diabetic retinopathy, or any proliferative retinopathy predisposing to ocular hemorrhage. The patients undergoing vitrectomy were evaluated at 3 time points: at the time of diagnosis, 1 month post vitrectomy, and 3 months follow-up, or the last follow-up, whichever is later. So they had a comprehensive ocular examination, including BCVA, intraocular pressure, fundus examination, and in the event of occluded fundus view, B-scan ultrasonography was done. The parameters assessed were age, sex, etiology of intracranial bleed, timing between intracranial bleed and vitrectomy, and any surgical complications. The outcomes measured were change in BCVA from baseline to the last follow-up, and also association of final BCVA with the timing of surgery with a cutoff of 90 days, and age less than or more than 50 years, and etiology of intracranial bleed. So for the patients undergoing vitrectomy, patients with persisting VH after minimum of 1 month of observation and a visual acuity of less than 660 were taken up for vitrectomy. After a well-written informed consent and neurosurgery clearance, the patient underwent a 23 or a 25 gauge pars plana vitrectomy, and the additional procedures were performed as per indication or surgeon's discretion. So there were 40 eyes of 32 patients in the age group of 24 to 73 years. 18 eyes were managed conservatively. 2 eyes were advised surgery, they did not follow up. And there were 20 eyes of 19 patients were taken up for pars plana vitrectomy. Bilateral Terson syndrome was seen in 8 patients, of which 6 patients had aneurysmal etiology and 2 had traumatic etiology. Out of the 8 patients, both eyes were managed conservatively. 5 patients, 1 eye surgical and another eye conservative, and 1 patient underwent bilateral vitrectomy for Terson's. So total of 20 eyes of 19 patients were included, with a mean age of 46, with a range of 24 to 73. Mean time of surgery after intracranial bleed was 108, with a range of 24 to 273. So coming to the change of baseline visual acuity, best corrected visual acuity, there was significant improvement from 1.94 to 0.19, which was statistically significant, and it was maintained maintained up until last follow-up, with more than 80% of the patients maintaining a visual acuity of 6/18 or better. Etiology and visual outcome. 10 eyes were traumatic etiology, 10 eyes were aneurysmal etiology. Out of the aneurysmal etiology, 5 were anterior communicating artery aneurysms, 2 were MC aneurysms, 1 was IC aneurysm, and 1 vertebral artery dissection. Both the groups did significantly well post-surgery, and there was no difference in the visual outcome between the 2 groups post-surgery. Timing of surgery. 9 patients underwent vitrectomy less than 90 days, and 11 underwent vitrectomy more than 90 days. Both of the groups performed significantly well post-surgery, and there was no difference between the visual outcome of the 2 groups. Between the age and visual outcome, 12 were less than 50 years of age and 8 were more than 50 years of age. Though the less than 50-year-old category performed slightly better than the more than 50-year-old, the difference between the 2 groups was not statistically significant. So this was the charts of all the patients who underwent vitrectomy. And in addition to vitrectomy, ILM peeling for a taut ILM and a sub-ILM bleed was done in 13 patients. Endolaser was done for 11 patients. And ERM removal for 1 patient and transconjunctival cryo for 1 patient. And 2 patients, case number 1 and case number 9, underwent cataract surgery later. And the ones marked in yellow were bilateral Tersons, and the last 2 cases were 2 eyes of the same patient who underwent vitrectomy with a good visual outcome. So to come to discussion, significant and dramatic improvement in visual acuity 1 month post vitrectomy, and it was maintained over a mean follow-up of 6 months. And the presenting visual acuity may not be a useful prognostic indicator to assess the final visual potential. Garveg et al. In 2009 did a study and told less than 90 years and less than 90 days and less than 45 years was a good prognostic indicator for visual outcome, but this was not seen in our case, and the etiology also did not affect. To conclude, early vitrectomy is a safe option and gives early visual rehabilitation in these patients, and the patients can be safely observed conservatively for an extended period without the risk of reduced visual potential if they are medically unstable. The strength of the study is the case numbers of the study, and they were performed by 5 different surgeons, limiting procedural standardization, and the less follow-up because of the comorbidities associated, and visual field analysis could have given a better understanding of the neuroophthalmic outcomes of the patient. Thank you.
You explained that it is a non-resolving vitreous hemorrhage, but
Yes,
we
sir.
had considerable number of patients undergoing vitrectomy within 3 months. No.
So, 3 months of,
So how do you define non-resolving?
sir, precluding fundus view, I had defined it as they were observed for 1 month after presentation.
You took 1 month as a cutoff for non-resolving.
No, sir.
Ah.
From the time of intracranial bleed to the surgery was a time assessed,
No,
sir.
no, no. You said for non-resolving vitreous hemorrhage.
Yes, sir.
Non-resolving means you should have a time frame.
Yes, sir. They were observed for 1 month
1 month was your cutoff for non-resolving.
after presentation to the OPD, irrespective of the time of intracranial bleed to the presentation.
At the hospital, from the first presentation from the hospital visit.
Yes, sir.
Okay.
Very good series. But two things. The one, visual acuity was studied, no?
Yes,
So
sir.
but there could have been a effect of the optic nerve that could have been. Was that studied? Any attempt made to study
Some
that in
patients
any
had undergone a pre-operative VEP. For other than that, nothing post-operatively,
post-operative
nothing.
color vision, RAPD, post-operative? Nothing was mentioned in the
Neuroophthalmologically
evaluation. Was not
not
done. And second thing, any OCT? Why OCT was not part of this
It is
thing
not there, sir.
post-operatively also?
The post-op, our follow-up was very limited.
Because these are subilam
Patients
bleeds, so we'll know what is happening at
Yes,
the.
sir, yes.
I had the same thing to ask. In the traumatic cases, especially the CNS injury might be a confounding factor
Yes, sir.
in the visual.
Another thing, OCT could be a lamellar hole or a EZ loss or macular hole. Those things should be assessed. No?
Yes.
So that's very. Yeah. Now, the next paper titled Real World Experience in Treatment of Eyes with CNVM Switched to Intravitreal Brolucizumab. Dr. Asha Purna Burgohain
Yes.
is going to do that.
Yes.
Thank you.
Good evening, everyone. I'll be presenting our study on real-world experience in treatment of eyes with CNVM switched to intravitreal brolucizumab. As we all know, neovascular ARMD and PCV are chronic recurrent diseases. The challenge at present is the burden of frequent injections, and over time, some cases lose responsiveness to the treating anti-VEGF. And very few studies have evaluated the outcomes of brolucizumab in such poor responders. We aim to study the functional and morphological changes in eyes with type 1 CNVM in neovascular ARMD and PCV switched from any other anti-VEGF to intravitreal brolucizumab. Our outcome measures were change in CMT, best corrected visual acuity, subretinal fluid, intraretinal fluid, PED height, choroidal thickness, and mean number of injections. It was a retrospective and single center study which included patients of more than 50 years of age, type 1 CNVM in neovascular ARMD, and PCV with subfoveal polyp on ICZA. Patients who received more than or equal to 3 anti-VEGF before switch to brolucizumab and who had a minimum follow-up period of 6 months after the first dose of brolucizumab. We excluded patients who had any coexistent retinal diseases affecting the macula, previous history of laser or PDT, or previous history of uveitis. We collected patients from the EMR and evaluated their parameters like the OCT parameters and BCVA. OCT parameters we studied from the subfoveal section or section through the polypoidal PED, and we evaluated them immediately before the last other anti-VEGF at the time of switch 1, 3, and 6 months after the first dose of brolucizumab. All the patients were examined under slit lamp for inflammation at first week post-injection and at every visit. Further intravitreal brolucizumab were given on a PRN basis depending on persistent SRF with one-line drop in Snellen's visual acuity, increase in SRF or IRF or both, or presence of hemorrhage clinically. The decision for switch was taken based on inadequate or partial response or no morphological response or patients requiring frequent injections. We defined inadequate or partial response as reduction of 25 to 75% from the baseline, but not total absence in terms of OCT parameters like SRF, IRF, or CMT, and no response as no change or increase in the OCT parameters. We examined 45 eyes of 42 patients. Majority were males. Mean age was 71 years. Mean duration of follow-up after the switch was 10 months. The interval between first and the repeat dose of brolucizumab was 3 months. Pre-switch, around a similar number of patients had received bevacizumab and ranibizumab, followed by patients who had received multiple switches, followed by patients who received aflibercept. The majority of patients were switched because of inadequate response, followed by no response, followed by frequent recurrences. The mean change in CMT post change to brolucizumab at 1 month was statistically significant. Mean change in BCVA from the baseline at switch was a gain of 4 ETDRS letters, and at 6 months it was maintained. At baseline, at the time of switch, around 79.2% of patients had SRF, which drastically changed to 25% at 1 month, and it gradually increased at 3 months and 6 months. However, the BCVA was stable at that points. In terms of in the change in IRF, at switch, 41.7 patients had IRF, which changed to 10.4. And at 3 months, when there was recurrence, most patients were injected, and it reduced to 25%. There was significant change in PED height 1 month after the injection, after the switch to brolucizumab. This is a subgroup analysis of PCV cases where we can see pronounced reduction in PED height. In the right side, in a case of PCV, there is complete collapse of PED after switch to brolucizumab. 2 eyes had complete collapse, 9 had reduction, and 2 had no response. There was significant reduction in choroidal thickness after the switch to brolucizumab at 1 month. And an average of 1.77 injections were needed after the switch to brolucizumab compared to 3.04 injections before the switch within 6 months. There were no safety issues during the follow-up. This is a representative case of type 1 CNVM in ARMD. On the left side, we can see the patient was not responding to multiple doses of bevacizumab and ranibizumab. And after switch to brolucizumab, there was complete absence of fluid, which remained dry even at 3 months and at 6 months. This is another case of PCV where we can see on the right side who had a subfoveal PED with SRF, which responded initially to aflibercept, and later on the patient became non-responsive, and the patient was shifted to brolucizumab when where the fluid was completely gone with collapse of PED, and recurrence was seen only at 6 months. So reduction in CMT and compartmental fluid like our study was seen in Braille, Shift, and Reba study. Reduction in PED height was also seen in Rispoli et al. Study, and a tolerable amount of SRF, which was seen in many cases in our study at 3 months, was seen in fluid study. There was no ocular events, unlike Hawk and Herrier and Braille study. The limitations of our study includes it is a retrospective study, and different antivisive agents were used prior to switch, which could have introduced bias and restrict the applicability of the findings. To conclude, in patients of ARMD and PCV switched to brolucizumab, significant improvement in morphological parameters were noted. BCVA gain was seen, which was maintained in further follow-ups. Most importantly, treatment-free interval was longer, thereby reducing the frequency of injections. Thank you. Thanks.
So the next speaker is Dr. Nimita Vijayan. Okay. You are presenting OCT biomarkers for good visual outcomes after cataract surgery in presence of epiretinal membrane.
Yes.
You
Yes.
can proceed with your
Coming to
presentation.
introduction, the idiopathic epiretinal membrane is a proliferation of glial tissue on the surface of the macula. Its incidence of 5.4 is present. Prevalence ranges from 4 to 8.5%. 90% of patients remain asymptomatic. The epiretinal membrane and cataract commonly occurs together, and detection and grading and assessment for visual outcomes is necessary for treating the mode of surgery that is needed. The need of the hour to establish markers to identify the preoperative characteristics that may be a predictive value and would justify the necessity of a combined surgery need to be addressed. Briefly, the pathogenesis. The 5 types of cells involved are the RP, the fibrocytes, the fibrous astrocytes, the macrophages, and theories. The microglial cells migrate the segments of the cellular which remain on the retinal surface, thereby creating avulsion defects. In the era of OCT, we have differentiated the ERM based on 4 grades: in the presence of a foveal pit and the definition of the retinal fiber layers. And coming to the study, there are various lacunae in the other studies. They have all studied the magnitude of the visual acuity and the incidence of CME, the progression of ERM following cataract surgery. Neither the history of the ERM after cataract surgery nor the prognostic factors were implicated. So in the present scenario, it is important for us to decide the mode of surgery that is required for a patient. Are we over-diagnosing these cases? Are we over-treating these patients? All these need to be addressed. And hence, coming to my study, which aims at analyzing the post-operative visual outcomes after cataract surgery in the presence of an idiopathic epiretinal membrane, and to analyze the predictive factors for a good visual outcome. The materials and methods, it is a retrospective study in the Department of Vitreoretinal Sciences, Chaitanya Hospital, for a period of 6 months. 37 eyes of 37 patients were included. The inclusion criteria being eyes diagnosed with cataract and idiopathic epiretinal membrane. Exclusion criteria combined surgery patients, secondary ERMs, PCR patients, coexisting retinal pathologies. The data and parameters, all the preoperative parameters were included, and the SD-OCT using the spectralis machine was done. Post-operatively, after 6 weeks, the vision was taken and categorized into 2 groups. Group 1 included poor visual acuity group, that is without 2-line improvement, and Group 2 included a good visual acuity group with 2-line improvement. And the OCT parameters analyzed were the foveal contour pit, the central foveal thickness, intraretinal irregularities, ELM, EZ disruption, ERM staging, taut hyaloid, posterior hyaloid, and subretinal fluid. Coming on to the results, 13 patients were included in the Group 1, that is a poor visual acuity group, 24 patients in Group 2, that is a good visual acuity group, and the mean age was 71.08. The preoperative CFT was comparable in both the groups. The statistically non-significant parameters included the grade of cataract, the ERM grading, the subretinal fluid, foveal contour, the intraretinal irregularities, the ELM, EZ disruption, taut posterior hyaloid, and the ILM dehiscence and drill were all statistically significant parameters. Coming on to the discussion, the stage of ERM. 61.5% patients in the poor visual acuity group had type 1 ERM. So this implicated that the staging of ERM had nothing to do with the visual outcome. Jose et al. In his study had also, in accordance with our study, reported the similar findings. However, the presence of an ectopic inner foveal layer, as evidenced by Govito et al., showed that there was a lower visual acuity in such patients. The intraretinal irregularities was present in 84.6% patients, and they had poor visual outcomes. And this was evidenced again by Kwan et al., who also had a similar finding, and they had stated that it is a better marker than the CFT interdigitation zone for prognosticating visual outcomes. The ELM EZ disruption was present in 76% patients, and all of these belong to the poor visual acuity group, as evidenced by Tiago et al., Jose et al. In their previous studies. The interesting part, the good visual acuity group patients had no taut posterior hyaloid, and hence taut posterior hyaloid is an indicator of anatomic and functional ERM progression, as evidenced by K. Bet et al. The ELM dehiscence was present in 55% patients with poor visual acuity, and also evidenced by Lee et al. In their study. What they had seen was 53.5% patients with ILM dehiscence. There was a delay in the post-operative restoration of the inner retinal layers, so implicating low visual acuity. The drill was another significant biomarker, and 68% patients had poor visual acuity who had drill in them, and drill grading function was an important factor for the functional and anatomical measure for predicting the visual outcome. Now coming on to the other parameters, the CFT, the foveal contour and the subretinal fluid, all of these were little significant parameters. The other biomarkers which had a numerical value but did not show statistical significance was the presence of subretinal deposits which had a lesser visual acuity, presence of sukema, there was improved visual acuity, and the prose length longer the better. The coming on to the conclusion, the positive biomarkers included the intact IRL, the intact ELM, attached vitreoretinal interface, absence of HRF, the negative biomarkers, intraretinal irregularities, ELM, the taut posterior hyaloid drill, the ILM dehiscence. Limitations of a study, lack of data regarding pre-op metamorphopsia, small study, non-randomized study, retrospective short follow-up period. Take-home message, and this is what we currently use in our clinical setup. The following biomarkers were associated with poor visual acuity after cataract surgery: the ELM, EZ disruption, drill, the presence of intraretinal cysts, schisis, hyperreflective foci. All of this implicated the presence would indicate the need of a combined surgery, that is a cataract plus a vitrectomy. However, the following features associated with good visual acuity, that is the intact IRL, the ELM, EZ, attached VR interface, absence of HRF, implicated that the patient just requires a standalone cataract surgery, and the pre-op foveal contour and CFT was controversial, and the BCVA and inner retinal deformation was reversible. The BCA with outer retinal damage was irreversible. The prognostic factors of ERM following cataract surgery may help in a better counseling of patients and a better surgical outcome. Thank you.
Your success parameters was improvement from presenting vision. Is that right? But that will be a little bit vague, no? Suppose the patient comes with a near mature cataract with very poor visibility, and you are able to pick up on the OCT. You'll have a considerable visual improvement. So the amount of vision improvement will be more dependent on the severity of the cataract and the how low or how good the presenting vision is. Suppose the patient comes with 6/9 vision, he may not have even much of a scope ceiling effect will be there. So ideally, should have taken a final post-operative visual acuity and tried to correlate that with whatever parameters you have put up.
That was taken. So post-operative visual acuity was a standard of our thing.
But when you said good vision and poor vision in the initial slide, it seemed
post-operative finding.
no. How did you classify as good vision and poor vision? Good outcome and poor outcome.
Good vision is patients with two-line improvement, and poor vision.
That's what I'm saying. That's what I'm saying.
Okay.
So you're saying improvement from presentation, no?
Okay.
So that will give a wrong idea of what is to be expected. You could have to go on with the final visual acuity post-op, and then correlated near 6/9 and better will be good vision, or 6/12 and below would have been something like that. You make a division and then try to correlate, rather than trying to look at the improvement from, because in our population people tend to come late for surgery sometimes. So they'll come with poor visual acuity, but the doubling will be very high because the presenting vision is poor mainly because of cataract. So it will totally confound your results. That's what I thought.
Even I had the same feeling. We could have taken actually pseudophakic when the study was OCT biomarkers and ERM. Cataract would have been a big confounding factor. Would have been better if you had selected pseudophakic eyes.
You could have gone with the final visual acuity rather than the improvement from baseline.
And taut posterior hyaloid, is it a confounding factor as far as final visual acuity is?
Yes, it was a good. It was a negative biomarker.
And was it associated with EZ loss or any other change, or independently a taut
Independently,
posterior hyaloid?
it was an independent finding.
One of your conclusion was that with drill you will go for a combined surgery.
Yes.
Is
No.
that correct? Yeah.
Drill combined surgery. Yes.
Combined.
It's a negative biomarker.
So rather than doing cataract, she wants to combine both. The things are okay, but only thing your initial parameter which you took for success was not very robust. That's what I thought.
Thank you, sir.